Hello, my name is Sandeep Devabhakthuni. I'm an assistant professor at the University of Maryland School of Pharmacy. Welcome to the Under Pressure, a focus series on hypertension. We will be discussing therapeutic objectives for managing hypertension. Without doubt, the primary objective in managing hypertension should be to reduce associated morbidity and mortality with cardiovascular events. These events include coronary events such as myocardial infarction and the reinfarction risk, cerebrovascular events such as stroke, and complications that come about with cardiovascular events such as heart failure and kidney disease. The reason why this has become our primary objective is because there is great data in the literature now that have shown that medications can significantly reduce the morbidity and mortality for cardiovascular events. In fact, because of our better understanding and more literature that has been published in this area, we now know that there is a reduction in morbidity and mortality significantly by medication therapy. And this has been a dramatic decrease in cardiovascular events compared to a couple of decades ago. So with this in mind, it is important to select medication that have been shown to be effective in reducing morbidity and mortality when managing blood pressure. How do you determine what the right blood pressure should be, what that goal should be? So in order to determine whether or not you get that reduction in cardiovascular events, we use the blood pressure as a surrogate marker. And the reason why we use the blood pressure as a surrogate marker is because there's good data to show that a reduction in blood pressure is associated with a reduction in cardiovascular events. So now how do you determine what the blood pressure goal should be? There actually were recent guidelines published in 2014 by the 8th Joint National Committee. They recommended first lifestyle modification including diet, exercise, weight, and alcohol. But they also provided guidance on what the blood pressure goal should be, depending on whether or not the patients have diabetes or chronic kidney disease, and also their patient's age. If the patient is elderly, which is defined by the guidelines as age greater than or equal to 60 years old, they should have a less stringent goal for having a systolic blood pressure less than 150 and a diastolic blood pressure less than 90. The rationale behind using a more or less stringent goal was to avoid hypertension in these patients who are elderly. For patients who are less than 60 years old, the recommendation is to have a blood pressure less than 140/90. For patients who have diabetes or chronic kidney disease, the recommendation, it doesn't matter regardless of their age, they should have a more stringent goal of less than 140/90. And this is true for regardless of whether or not there's diabetes or not. All patients should have a goal of less than 140/90 if they have CKD plus or minus diabetes. Now, what's interesting is that there are also other published guidelines from different national organizations that were recently in the literature. And what they've actually had slightly differing recommendations compared to the 8th Joint National Committee. And so I wanted to highlight some of these differences. One thing I wanted to first talk about was high-risk patients for cardiovascular events. And so the American Heart Association, American College of Cardiology, and the American Hypertension Society defined high-risk patients as those who have CAD, who are post myocardial infarction, had a previous stroke, or has a history of peripheral arterial disease and other factors. these patients, what the recommendation was to decrease their blood pressure less than 130/80. And this is because there's data to show that having a further reduction by being more stringent can lead to further reduction in cardiovascular events in these patients. And so that has become their recommendation, which is not really defined in the 8th Joint National Committee guidelines. Another thing I wanted to highlight is the diabetic population. If you recall from the previous guidelines, the 7th Joint National Committee guidelines recommended that for diabetic patients, the blood pressure should be less than 130/80. However, with these new guidelines, this has now become less stringent, and now we have the blood pressure being less than 140/90. And the reason for this is because there was limited data to support less than 130/80, and there was very few reports that it actually improved outcomes. So that was why there was a less stringent recommendation going forward. And then finally, one important difference that I really wanted to highlight is the age stratification for having a less stringent goal for blood pressure reduction. And the 8th Joint National Committee, as I mentioned earlier, they had the cutoff as age of greater than 60. However, if you notice, the other guidelines commented they had a higher age cutoff of 80 or older in order to have a less stringent goal. And I wanted to discuss why this came about. So there was a couple of main trials that I really wanted to discuss while there are other trials. The ACCORD trial was the first one that I wanted to discuss, which was done in type 2 diabetic patients. And these patients were randomized to either have intensive blood pressure control with the blood pressure less than 120/80 versus the standard, which the blood pressure less than 140/90. And this one actually did not really see much of a significant difference in the cardiovascular outcome, with the exception of stroke. And one interesting finding was that there was a statistically non-significant decrease in cardiovascular disease events if there was a decrease in the diastolic blood pressure. So this trial really confirmed that the diabetic population did not really need to have a more intensive blood pressure control. And this led to the relaxation of the blood pressure goal to less than 140/90. Then there was a landmark trial that came out in 2015 called the SPRINT trial. And the SPRINT trial looked at non-diabetic patients who had a high risk for cardiovascular disease. And the patients, again, were randomized to either the standard treatment group or the intensive treatment group with the same blood pressure goals as mentioned in the previous trial, the ACCORD trial. And what they found was there was a statistically significant difference in cardiovascular outcomes when there was an intensive treatment, which means that they got the blood pressure less than 120/80. And what's interesting is these patients also had elderly patients that also saw the same benefit. And so this led to some of the organization, including the American Heart Association, that disagreed with the 8th Joint National Committee recommendation for having a more stringent goal or less stringent goal for blood pressure. So this led to some controversy about what the blood pressure should be for these patients. And as of now, it's really meant to be a clinical judgment. If you think that the patient who is over 60 years old and is high risk for cardiovascular disease, I certainly think it's reasonable to target a lower blood pressure goal of less than 140/90. However, if you notice that your patient is having issues with adverse outcomes, such as hypertension, risk of falls, you might then choose to have a more lenient approach in keeping their blood pressure less than 150/90. There are ongoing trials that will also help to clarify what the correct blood pressure should be. But in general, we tend to be more aggressive in keeping their blood pressure lower than 140/90 between the age group of 60 and 80. This concludes the discussion of the therapeutic objectives. To learn more about the other aspects of management of hypertension, please visit our YouTube channel to see other videos. Thank you.